Hey guys, usual crew on a Friday night. So last one of the week, and we've got to finish off this patient J, the pregnant 17-year-old. If I'm sure I know everyone on the list, but if you don't, hi, my name's Mike, and I run movement therapy education. So we run training courses. Hey everyone. I may might have time to finish. Okay, no problem. Yeah, no problem, Catherine. That's fine. Yeah, so I did a bit of a session on Wednesday about the initial consultation and the kind of information you need in that initial form, and how it changes as well as you get more experienced and develop your kind of clinical skills, your clinical reasoning skills. So I think when I very first started, my form was really long, and now I've got real key questions that I use. But it's all from the differential diagnosis book. That's how I've created my form and put it all together. In that book, there's a really good section in it where at the I'm not sure how they do it now, but when I got the book, it was on a CD-ROM, so I'm guessing it's online now. But they had a CD-ROM with all of the checklists for all of the systems. So as you go through the systems review, so if there's a heart problem, then these things will come up on your questions. If there's a lung problem, then these questions will come up. So that book is really good for honing in on specific conditions. So yeah, well, hopefully watch it back, and we'll give you a few tips there. Well, hopefully in early June, we've got because I've run a clinic with a multidisciplinary team, so we've got physios, osteos, podiatrists, sports therapists, personal trainers, strength and conditioning guys. So a lot of those areas are a no-go at the moment, so we can't see patients face to face. Some of us can, so I have been able to all the way through the COVID-19 pandemic, but I haven't felt comfortable to, and I don't have the systems, procedures, and PPE in place to do things safely. So I've just not done anything at all, and just focused on this really, and focused on the education side. But our podiatrists, as they've got some real strict guidelines from their awarding organisation. So our podiatrist will be back in the next sort of 10 days, which is great. So he's going to be back in clinic on his own. So we're just painting the clinic and getting it all ready. And I guess you guys who work in clinics as well, I think the magic date of July the 4th has been mentioned. So anything that I can produce for my clinic, I'll pop it on our CPD group so that you can get some ideas. There's some really cool things coming out from Italy because the physios have gone back to work there, and I did a bit of research as well, and there are osteopathic clinics open in Italy as well, so, and you can book online. I tested out the system and to see whether they had any appointments available. So they are going back to work, which is good, and I guess we'll learn from how they go back to work as well. So yeah, anything like that, then I'll repost. So I'm the West Midlands rep for the Sports Therapy Association. So again, anything I get, I'll feed over to Gary Benson, who runs the SDA. So but he'll probably get it anyway. He's well connected within those kind of worlds. So this is what I've not here in Wales. Okay, yeah, different countries, I guess, different things. Yeah, I used to live in North Devon, and part of the North Devon Facebook groups, and the locals are going crazy with everybody going to the coast, and it's quite an elderly population down there as well. So there's no chance of social distancing with the amount of people that are on the beach. So yeah, it's different for different parts of the world, I guess. So this is what I've been doing. So I've been doing some online stuff, and I know I've mentioned this before, but we've just launched another PODS course. So we're doing a cupping course, and The reason why I wanted to do it was to show you that it can be taught online, so that you can teach your patients. And the idea is that we, in the Rock Tape team, we produce patient packs. So you can give a code to your patient, they can buy the patient pack, and then you can talk them through how to treat themselves, and do all the areas that are accessible. Or if their other half is there, then obviously the areas on the back. So and taping as well, because there's a lot of taping techniques that you can do yourself. If someone's injured their ankle or something like that, then you can easily tape up your own ankle. So I'll show you how to do that online. So if you're interested, just pop up the link there. There you go. So you can click on that and have a look. So we're going to finish off this week. So the plan is what do we do with this person? What might be going wrong? So these were the key points from the SIV from the last couple of days. So we had a 17-year-old recently found out she's pregnant, and she's arrived with her controlling mother. Okay, so you get an image already of the kind of situation that she's in. She's had Nurofen on and off since she was approximately 14, which was not going to go into that too much detail, but a bit of a problem in pregnancy. Okay, so if you have a look at the effects of ibuprofen and taking ibuprofen when pregnant, then you'll be able to see that it's not a good idea. She's come in and she feels tired. Okay, that was mentioned a few times. She had a constant ache and stiffness in her right shoulder, which travelled up to her neck. Entire arm aching, feel heavy, and intermittent pins and needles in her entire hand. So we had this kind of presentation before on a few of the OSCEs we've done, and it was pointing towards a kind of thoracic outlet syndrome. Yeah. So if it's a nerve root problem and it's affecting a specific level, then it's usually symptoms following what we call a radicular pattern, so a pattern that follows a particular nerve pathway. But when it's the whole hand, it's usually the blood supply that's affected, or several nerves. And it could have been several nerves in this case, because one of the things that happened to her was she fell off a horse and wasn't checked. And she fell on her chin, which then hyperextended her neck. So there could have been some compression of several nerve roots, I'm guessing. But you would have imagined that, because that happened some time ago. So you would imagine that if that, when was it? Yeah, 6 months ago. So if that was the cause of the issue, then she would have probably felt that pretty much straight away, you would imagine. But still could have symptoms related to that down the line too. So that was kind of something in the back of my mind, right? Okay, yeah, it could be something to do with that. Sharper pain in upper right thoracic area on standing up straight. So when you stand up straight, and in that kind of position, you can bring the facet joints in the thoracic spine closer together. So if she's got a bit of an irritation in those thoracics, then that can cause a bit of a pinching sort of feeling, and that's quite common. Yeah, quite common to get those kind of symptoms. But then a little bit further down, so if I just pop this on, yeah, so here, so this line here. So since her early teens, she has suffered with pains in her thoracic spine and periscapular muscles, so the muscles around the scap. She was diagnosed with an idiopathic scoliosis, so a scoliosis with no known origin, and but it was not severe enough to consider surgery. So there's obviously something going on with that thoracic spine, and she's getting this kind of pinching feeling in that region as well. Okay, so yes, something to explore, which we'll have a look at in a sec. So she fell from a horse 6 months ago, fell on her head, well, fell on her chin. Okay, as I said before, extended her neck. But the symptoms in the arm started quite suddenly a couple of weeks ago, and worse after mucking out the stables. And she was right-handed, and it seemed to kick off when she was carrying a heavy bag over one shoulder. Okay, so a rucksack on one shoulder. So that can compress the brachial plexus, can compress the neurovascular bundle that goes underneath that collarbone. So that's the nerve and the blood supply. She also these were kind of hidden in there. These were kind of sneaky ones, really. So we've got a really bad chest infection 4 months ago, still feels a little breathless, and it's got worse recently as well. So we're going to have a look at that in a bit more detail. And this one as well. So along with the tiredness, headaches, and she's had those for a long time, so since she was 7 years old. And then she reports that she feels cold, and there was something wrong with her voice. Okay, so that was the only clue in there, and it leads towards a specific condition. So let's have a look at these. So juvenile thoracic disorders. So she's at 17, and one of the disorders that you can have as a juvenile is Shermans disease. It's called, although it's really a disease, but that's what it's called. So we're going to have a look at that in a bit more detail. That would be a GP referral. And then blood supply or nerve symptoms, thoracic outlet, carpal tunnel is your usual Adson's, Roux test, Phelan's test, upper limb tension test, neurological exam. So all the usual things that you could do in clinic. Nerve root irritation, compression, potentially because of the fall on the head and the symptoms in the arms. So they were kind of linked. And that one I had at A&E because she wasn't examined when she fell off a horse. And I mentioned on Wednesday that I saw someone once that 6 months previously had a problem with their shoulder, and then it flared up again, and it was a fracture. And I think they injured it carrying something in work, quite heavy, and then in a shoulder barge in football, and then it started to get painful again. So sent him off to A&E because it just did not look right, and he had a fractured humerus. So and because of the X-ray, we assumed it was an old one. Okay, because of the findings on the X-ray. So it could be a fracture of the cervical spine. Anything like that that's not been investigated properly, or they've just kind of poo-pooed it and just carried on, I'd recommend that they get that checked out. Okay, and especially if it's in the neck, then that's an A&E job. So fatigue and breathless, that was in there a couple of times. You can have post-viral asthma. Yeah, so she's had this chest infection, and now she's had this problem with breathlessness and fatigue. So she can have post-viral asthma, and pregnancy-induced asthma as well, and possibly an iron deficiency anemia. And I think a couple of you on the Facebook page come up with that, so that was really good. And then the one that was this is a real kind of curveball one. You probably never ever heard of this before, but something wrong with the throat could be something to do with the thyroid, and it is linked into pregnancy as well. Can be more prevalent with pregnancy. It's Hashimoto's thyroiditis. Okay, so we're going to have a look at that in a bit more detail. So Hashimoto's is caused by the immune system, and it attacks the thyroid gland, making it become swollen and damaged. Okay, so you may experience what we call a goiter. So it's where the throat starts to get bigger and swells around that around the thyroid. As the thyroid is destroyed over time because the immune system is attacking it, it becomes unable to produce thyroid hormone. Okay, so this can lead to symptoms of underactive thyroid gland, which is hypothyroidism, and this is things like tiredness, weight gain. So basically, your metabolism just slows right down. Okay, you can get tingling and numbness in the hands and fingers, dry skin. Okay, so there's a number of things that were in the history. Although they were linking towards the heavy rucksack on the shoulder, when you link those things with the throat symptoms and the hoarseness in the throat, then you could link it possibly to a thyroid issue. Okay, it was a very tenuous link, and it was only literally like 2 words. So yeah, difficult to spot. It can develop during pregnancy and cause complications, and may also develop after birth, and it's called postpartum thyroiditis. Okay, the swollen thyroid might cause a goiter, which we was talking about before. So a lump forms in your throat. So that they feel like something's there, and it often develops over time as well. So it's not something that's all of a sudden is there. It kind of grows slowly over time. So it's usually a slow developer. Oh, there you go. So it may take months or even years for the condition to be detected because it progresses very slowly, and it can lead to anemia. And we talked about anemia before as well with the tiredness too. So there's a few things within the history that you think, oh yeah, it's probably anemia, but then okay, what's causing the anemia? And the hoarse throat comment might have been something that you would have. And this is the thing with the forms that you fill in that I was talking about on Wednesday. Unless you specifically ask about those types of questions, you would never know. But that question is on my form. Okay, so have you had a hoarse throat? Have you had difficulty swallowing? Those kind of things. And that's on my initial assessment form, because that's part of the assessment I do for the endocrine system. Okay, so the thyroid in particular with those questions. And if you have problems with regulating temperature, so she was complaining about being cold. Yeah, so problems with temperature control and possible changes in metabolism, then it could be linking into some kind of endocrine disorder. Okay, so that's a very, very rare one. Okay, so wouldn't be surprised if no one had a clue what the heck it was. But yeah, it was an interesting OSCE, this one. And then Shermans as well. So Shermans is this. So Sherman's kyphosis, also known as Sherman's disease, is a juvenile kyphosis or juvenile discogenic disease. Okay, so it's something that you can't control. You don't do anything to cause it. It just happens. So it's a condition of hyperkyphosis, involves the vertebral bodies and discs of the spine, identified by anterior wedging. So basically the front of the disc starts to collapse down. So then that causes a structural deformity. Yeah, so you have a physical change to the position of the spine. It's not just like having poor posture. It is a physical change to the structure. Okay, so if they're equal to 5 degrees in 3 or more adjacent vertebral bodies, then that is considered to be Sherman's. Okay, the thoracic spine is most commonly involved, although involvement can include the thoracolumbar region as well. This is usually in juveniles, so adolescents aged 12 to 17. Okay, and they'll usually present with a postural kind of hunchback deformity. So it doesn't matter how many rows you do, how many reverse flies you do, how many scapular retractions you do, you're not going to change the position of that spine. It's changed internally. Yeah, so the structure has changed. And it's the most common cause of kyphotic deformity in adolescents. Yeah, so if you get a young adult in your clinic, and they'll get a lot of restriction in that region. And remember, she had a bit of a pinch as well in her thoracics when she extended her spine. So again, I mean, so the picture here is obviously quite extreme, but you would notice hypomobility in that region. Okay, so it's a hereditary component is understood to contribute to the condition. Any treatment possible? Not really, Peter. Not that we can do anyway. It depends on how bad it is, but they may have surgery for it. But it depends on how it's affecting them. What we do, because we've got someone in the clinic with Shermans, and what we do is we try to maintain what they've got and slow down the mobility loss. Yeah, so we just try and do loads of mobility work with them on their thoracics, and the lumbars and the cervicals as well, because if those areas above and below are restricted, then it's going to overload the thoracics, and could make it more painful. It wouldn't make it necessarily worse, but possibly more painful. Usually get pain in the affected hyperkyphotic region, and that might be the reason why they come in. Okay, so they've got kind of pain in the middle of their back, but when you do an examination, it doesn't really move. It's really pretty stiff. Okay, Yeah, so it's usually hereditary, and the clinical test you can do is something called occiput to wall test. So you basically stand up against the wall, and if you can't touch your head against the wall, then that's a positive test. Okay, so I'll see if I can find a picture for you. Bear with me a second. Good old Physiopedia. Right, let me just show you this. I'll just share this with you. Okay, so this is the occipital to wall test. They just basically stand against the wall and you see if they can get their head to touch the wall, and you measure the distance between the occiput, which is the back of the skull, and the wall, and see what position they're in. Okay, so OWD, so the occiput to wall test, that one. Okay, right, just get off of that one. Cool. So another new clinical test to add to your toolbox. There you go. So you got the occipital to wall test in clinic, and then you should then refer for an X-ray to have a look at what they call the Cobb's angle. And that's the angle that they use to measure the vertebra. So each vertebra is compared against the next one to see whether there's an angle of 5 degrees or more in 3 adjacent vertebrae. Okay, so it would be done at the hospital, but you may pick it up in the clinic, and they come in and they didn't know they had anything wrong, and you look at their back, and because they've lived with it all their life, they think it's normal, and then you look at it and you're like, oh, okay, I think you need to go and get that checked out. It may not be causing them any problems at all, and they can live with it, no point. It depends on what they want to do. So if they want, especially rotational sports, they're going to really struggle with thoracic rotation. So if they're a sports person, then they may feel it more. They'll struggle with the extension as well. Okay, so there may be clear biomechanical difficulties with this kind of presentation, and you think, oh, it's just a normal kind of restricted thoracic, but actually, if it's not improving, then they may need to get it checked out. Okay, so that it's not life threatening or anything, but it's something that may be just to alter what they can do throughout their life. Okay, cool. I've got Monday there, but it's going to be Wednesday. So I'm back on Wednesday because it's bank holiday Monday. So it's the last OSCE week. So week 10. So we're going to do a 2-day OSCE next week. Last one. I don't know whether I've got anything as exciting as Hashimotos thyroiditis. I'll see what I can dig out. But yeah, we're going to do the last one next week. So if you guys have got any things that you want to ask as well, then just pop it in the Facebook group. So there are any conditions that you want to cover, because having just a shorter couple of days might be able to add a few more bits in as well. So yeah, let me know. But I will see you next Wednesday at 6 o'clock. Okay, cheers guys.